Okay, welcome everyone to the Early Career Neuropsychologist Committee. Today we have Dr. Karen Postal, who's going to be discussing her excellent book, Feedback That Sticks. Just to say a little bit about Dr. Postal, she is board certified in neuropsychology and pediatric neuropsychology. She's a clinical instructor at Harvard Medical School, where she teaches postdoctoral fellows in neuropsychology and is the president of the American Academy of Clinical Neuropsychology. We should have invited you to be part of our work-life balance as well, considering everything you have going on. I'm sorry, say that again?
Oh, that's a whole another web hangout, isn't it?
Yes, yes. But you're obviously a very busy person, and you've written this very informational, very helpful book for neuropsychologists about feedback. And you're hoping that you'd be able to discuss some of your recommendations with us today.
Yeah, great. Absolutely. So what I thought I would do is just go through a couple of slides, maybe spend about 15 minutes orienting folks to what the research behind the book is about, and just giving a flavor of some of the richness of what feedback is. And then the majority of the time, I think it would be great to just do some back and forth conversation and answer questions.
That sounds great. Thank you.
All right, very good. So, this, I first want to acknowledge my co-author, Kira Armstrong. So we were working on this for about 3 years. This is kind of turned into a massive qualitative research project. And you can advance the slide. Our basic question was, giving feedback to people who have cognitive impairment and their incredibly worried families is really some of the most difficult thing that we do as a profession. And certainly when I was coming up, and most folks, there hasn't been a lot of research in the area or a lot of training in the area. And it's something that we all kind of learned on the fly. A lot of trial and error. Throughout my career, I would try a particular way of explaining a complicated phenomena. And, you sometimes see people glaze over and no one's listening to you. And then other times you really hit on these wonderful metaphors or analogies, ways of explaining that just it really creates access for people who are not in the field to understand what it is we're talking about. And when you hit upon one of those, you stick with it. It sticks with the patient, it sticks with you, you continue to use it. And so Kira and I thought to ourselves, well, what we really want to do is interview seasoned neuropsychologists, people who practice in all kinds of settings, private practice, university, tertiary care, with all kinds of patient populations, and literally ask them, hey, what do you say to people, right? How do you explain our methods, the test results, complicated neurological phenomena? So we ended up interviewing in-depth interviews with about 85 folks. And it was funny because as we started, people would kind of tell us in abstract terms what it was they were doing, and we kept saying, no, we want what you actually say. So we ended up, I have to say, just a treasure trove of clinical pearls. Like what are the best ways of explaining these phenomena? So that's what the book is all about, and we can go on to the next slide. And if you can just kind of move through the next series of slides. I just wanted to acknowledge all of our colleagues who were just so incredibly generous with their time and with their best pearls. Because Kira and I would be in an interview and we'd hear something and we'd be like, we're going to steal that one immediately for our practices. So this is a very extremely generous group of folks. Okay, so One of the first things we ask people is, hey, what is feedback? What is it you're trying to do in a feedback session? And you can advance it again. What we heard most frequently was what feedback is not. And you can go to the next slide, and you can advance again. Mark Barissa, who's hilarious, he had this great phrase, and he was like, you know what you don't want to do is diagnose and adios, right? If someone is putting that much time into the neuropsychological assessment, and you're going to sit there and give them a 15-minute, hey, here's the diagnosis, goodbye, that's really not necessarily worth their time, right? Muriel Lezak, when we interviewed her, said something very similar. She actually said, it is unethical to put someone through this kind of, really grueling, difficult assessment, and then do what she called a hit and run feedback session, which is just kind of give them a diagnosis and that's it. And you can move ahead. Most folks said, hey, it's not about the test scores. When I started out, I think when most of us started out, we're so focused on test scores that we forget that that's not why people came to see us. It's not about the scores. It's really about the bigger picture and how people's performance tell us about how their brain is working. You can go on to the next one. So what is it? It's not just test scores. It's not a quick hit and run meeting. And Mark Mahone just said it so beautifully. He said, it's the most integrated thing that we do. It brings together all of our knowledge and all of our training from every aspect of being a psychologist and a neuropsychologist. We draw just as much from everything we've learned about human development, psychopathology, family systems, social psychology, social power theory, leadership, psychometrics, as well as neuroscience in the brain, right? And there's such a beautiful, beautiful description of what we're doing. So I know this is an early career group, and that's probably like, oh, that's going to make people really intimidated. That's aspirational, what you're doing in a feedback session. Okay, we'll go to the next one. Most folks, acknowledge that feedback is really our psychotherapeutic moment. I love the movement towards the therapeutic assessment, and as human beings working with other human beings, we absolutely can and should be therapeutic throughout the assessment process. But feedback is really our opportunity to use our psychotherapy skills in the service of helping us understand the experience of the patient and the family system, and also helping us figure out a way to give them access to our message. You can flip it along. Another thing that's really important, and we can go back to some specific metaphors and analogies, but helping patients to understand exactly what it is they're dealing with. We've got a healthcare system where people may only spend 15 minutes with their neurosurgeon, or really have never had anyone explain what their middle cerebral artery stroke was about. And so part of what we're doing in the feedback session is explaining the basic neuroanatomy, the basic disease process, the basic developmental issues, but again, in a way that will create access. You can move ahead. Another thing that's really critical in terms of what our goals are in feedback is empowering patients and families. So again, Mark Mahone had such a lovely quote. He said, "It's my belief that we should try to change something about the family and the child's lives with our exams. So if we just give them the information and they walk out the door and nothing happens, we did not do our job." So then when they walk out the door, we want them to be inspired, empowered, and have access to new resources so that they can do something to change their child's life. So that to me, that's a really important piece of the puzzle. We're creating a psychotherapeutic moment. We're educating, but we're also empowering and really getting people to think about what are the next steps for them. You can move ahead. And you can, another really critical thing, this kind of goes to the therapeutic moment, but as neuropsychologists, we're dealing with people who are dealing with very difficult issues. If you might have a couple that's been married 50 years and one has Alzheimer's now, and the other is really grieving the loss of the person they've loved. Or you could be sitting in the room with a child with very, very severe cerebral palsy or some other developmental disorder like autistic spectrum disorder, and the parents are grieving what they thought the childhood would be like, or someone with a severe traumatic brain injury who has a family member. And patients are oftentimes so focused, or the family members are so focused on keeping a stiff upper lip and saying it's okay and what do I do, that the neuropsychology feedback session might be the first time literally ever that someone has invited them to express grief and think about the sad things. And there's a lot of ways that one can do that. Mike Kirkwood had a beautiful method. He said, he'll say to people, your child was not the only one who was injured. You were also injured, just not physically. And there needs to be a healing process for you too. Sometimes it's as simple as just, stop talking and then look at the family and say, hey, this is really sad. And then again, stop talking to open up some space for that kind of therapeutic venting. Okay, we can go to the next one. Okay, and so, a lot of what our research was literally not necessarily just about what you say, but how you say it. So how do you set up the conversation? Things like who do you invite, props, and then to me, such an interesting thing is really the social pragmatics of feedback, like the tone of voice, the body posture, the level of jargon, etc. So you can keep advancing. We talked a lot with people about feedback protocols, meaning where do you start, where do you go next, where do you go next? And lots of our colleagues, and I believe this as well, commented that feedback really begins at the initial interview. So Karen Wills pointed out that if the history is done well, then during the feedback session, 90% of your work is done. You know what the family's concerns were, what their theories were, the theories of the school, and so on. And those questions and issues provide the fundamental place where you begin feedback. So telegraphing potential diagnoses, figuring out where people have kind of prejudices, like, no one's diagnosing my kid with ADD, or what people are afraid of. I'm afraid that this might be Alzheimer's. Those are all such critical pieces of information. You gather them early, but you're using them actively in feedback. Okay, you can go on to the next one. So there's a couple of different, some people have, a hard and fast rule. We always start with the data, or we always start with the conceptual background of what the disease process is. Others, like myself, I'm very flexible. So if I have someone, maybe an adult who I'm seeing for a dyslexia evaluation, and they've thought their entire lives that they were stupid, and they come up with an IQ score in the 120s, man, I'm starting with that IQ score. So I'll sit them down and say, oh my God, you just aced the IQ test. And we'll start there, and then we'll work our way around to other topics. Similarly, if you have someone who came in worried that they had Alzheimer's disease, and your bottom line is that they don't, and it takes you 45 minutes to tell them that, they're not listening to anything you're saying during that 45 minutes. All they're thinking in their head is she going to say I have Alzheimer's disease? So if you can get something on the table, relieve anxiety, then you really have a space where people are going to start to listen. In other situations, it's great to provide some conceptual background. So Mike McRae, when he was talking with us about how he does a concussion feedback, he'll start with like, hey, what the heck is a concussion? And this is a temporary change in brain function, and we expect everybody to get better, and this is what the course looks like, and hey, here's your data, right? And so that's a reasonable way to go. Okay, we can keep going. Who attends? I think it was Bob Builder who said that the more people who are in the room when you're giving feedback, the greater the likelihood that something good is going to come out of it. So my theory is always to invite as many family members as possible. Blocking his name. Oh, I'll think about it. Anyways, one of our interviewees had said that he looks for the stakeholders in the family. So who's important? Is there a step-grandmother or someone who's really important to the child or the adult, and that person should be there? And if they're not, he scratches his head and he says, you know what, let's start a little bit of family systems work. Let's talk about why these people are not here. Okay, you can go on to the next slide. Prompts and technology, I'll just say, can be extraordinarily powerful. You can go on to the next slide. I do a lot of pediatric work, and I go to schools very frequently, and I'll sit at IEP team meetings. And I don't know how many of you who are listening do IEP team meetings, but you get into these like horrible like war of standard scores where you've got, you know, someone saying, well, Dr. Postal, we got a standard score of 89 on the processing speed test, and yet we see you got a 92. It's just a stupid conversation. So when I'm asked at a IEP meeting to present my report, I don't touch my report. I bring a 3D brain model and I pull it out of my handbag, and I say, well, you know, when Sally got a traumatic brain injury, severe traumatic brain injury 3 months ago, this is the frontal lobe, this was damaged, this is the part of the brain that brings us so much of what we value in successful students, and we go on from there. And so just having a prop, whether it's in your own consulting room or whether it's in a team meeting of some sort, is a great way to just drag the conversation to where you want it to be. Okay, you can go on to the next slide. There's tons of great data we got about social pragmatics. So the idea here is that you know, we all have a way of speaking, a way of being in the world, our body posture, tone of voice, but this can be dialed up, dialed down. It can be specifically manipulated if you are a clever clinician, so that you can meet certain goals. And we can go ahead and I'll give an example. I'm not going to go through all of these, but basically voice and authority is a great example. That, you know, a lot of times we have stuff that we need people to do, like we need people to take keys away from dad, or we need you know, someone to defer returning to school for a semester until they can get some more rehab. We have some tough messages to give to people, and you know, psychotherapy, if we've had that as our primary training, oftentimes we've been taught to take a one-down position. You know, we use a lot of soft voice and qualifiers, and we're not taking a voice of authority. But sometimes you have to be the voice of authority. Aaron Nelson said it so great. He said, you know what, sometimes people need us to be an authority figure, and we've got to learn how to step up and be that. So you can continue on. And you can keep, yeah, there's a couple of, and so there's various ways that you know, we've collected of how to step up that voice of authority, which I think is very interesting. I want to say, because this is an early career group, I just want to say a couple of things about dress and appearance. You know, one way to get folks to take you seriously is to be old, and that just comes naturally to us as you know, you go through your career. But I have to say, you know, when I was beginning, I specifically would dress to the nines, you know, wearing suits, being very formal, because I felt intuitively it would help people take me more seriously. And Cheryl Weinstein, who's so great. She actually tells her students, you know what? Wear glasses. If you don't need glasses, get glasses with regular glass in them. You know, do whatever it is you can to look more official, because that's going to help. And I'm going to share with you all my ultimate early career piece of advice for, you know, when you meet your the families of your patients, you're walking into a feedback session, or, you know, even when you're meeting them for the first time, and, you know, you walk out there, you greet your patient, and they look at you and they say, "Oh, you're really young." And you have this horrible moment where you're thinking to yourself, "Oh my God, that's right, I am really young. You know, wait. You know, I've got a doctoral degree, I'm board certified, I've got publications," and this nightmare is going on in your head. And you might say something, "Well, Mrs. Smith, I want to reassure you, I've been in practice for 3 years, I'm board certified." You know, but she's still kind of squinting at you, thinking like, "Huh, you look pretty young to me." So this was the technique I hit upon early on, and I actually don't have to use it very often these days, but once in a while a 90-year-old will pull this on me, and I'll pull it out. And I'll just sit, they'll say, "Oh, you're very young," and I'll look at them, big smile, and say, "Wow, you really made my day. Let's go back and talk about the results of the eval." Right? So you've used a little Aikido. You kind of have them a little confused, like, "Wow, she was really happy that I said that. She must be older than I thought," and you move on. Okay, you can go on to the next slide. I just want to say a little bit about diversity. You know, we're looking at a situation where by 2050, only 40% of the patients in our country are going to be, you know, monolingual, monocultural, English-speaking only folks. And so we really need to step up to the plate and figure out, you know, how do we create access to not only our test instruments and our assessment procedures, but how do we create access to everybody with our feedback message? And creating access means understanding worldviews, how people view jargon, etc. We had a great opportunity to interview Tony Wong just before he passed away. You can move on the, and I'm just going to say what he said because it was so beautiful. He said, "You know, you don't need to walk into feedback sessions with a complete a priori awareness of the cultural implications of our message, right? That would be impossible. We can't do it. We've got too diverse a patient group. Neuropsychologists are best able to pitch their message when they are open to engaging in a dialogue." This is so critical, and asking questions about their patient's culture. So it's important for someone from a different background to be okay with not knowing everything. So Tony said, "You know, even if I suspect I know a different culture well, it's important to give the patient the chance to tell me. So I will let them do so by directly asking, you know, how is this in your culture? Or from your background, how do you deal with this?" And he said, "When I'm on their turf, I find out about their turf," which I really love. I think is so important. Okay, you can move along. All right. I'm going to stop talking because I really wanted to leave the vast majority of this for questions. But I just wanted to share a couple of super cool, wonderful feedback messages that we collected. And you can go on to the next one. Yana Suchi, who is now our editor of The Clinical Neuropsychologist, she's brilliant, and she had the most brilliant ever way of explaining deterioration of brain function and improvement in brain function after a stroke. It's just so genius. And what she says to people is, you know, having a stroke, it's like there are 10 men carrying a log in your brain. That's your normal brain function. And after a stroke, some of those men might get sick and go away. So maybe you only have 8 men carrying that log. And you're not going to be able to do that thing as quickly or as well. But after a while, those 8 men, they've been carrying that log, they're getting really strong. And after a while, they may get so strong you don't even notice there's a change. But sometimes after a stroke, it's really, it's more like 8 men out of the 10 get sick and go away. And then you've only got 2 men carrying that log. And wow, they may be able to move the log, but boy, it doesn't matter how long time passes, they're never going to get strong enough to carry that log the same way. And then, of course, sometimes all the men get sick and go away. There's no one to carry that log. It's not moving anymore. Right? So you can imagine, after hearing something like that in a family conference at a rehab hospital, what's the one thing that family is going to take away from that rehab stay? That probably that metaphor. You can move along. You know what? I think what I'm going to do, I have a bunch of really cool pearls, but I'll leave them and I'll take questions, and then we'll, if we have time, I can come back to them.
Okay, if you don't mind, then we'll go ahead and get started with some of the questions. All right. So Callie, did you want to start with the first question that we had?
Yeah, absolutely. So one of the questions that I was kind of wondering, so I've read your book, which is super fantastic, and I was so grateful to get it as a gift from my internship. Yeah, it was great. So I wondered, kind of for you personally, what is the most difficult feedback that you have to give to patients? And how do you handle that difficulty?
That's a really great question. I think one of the most difficult feedback scenarios is when you're dealing with somatoform patients, right? And, pretty early on, after you've given like the fabulous news that their memory is great, and you see their face fall, you realize like, oh, okay, I'm in one of these moments. And rather than experiencing their beautiful, normal, healthy brain as a positive message, typically what happens is they experience it as, here's another person who isn't listening to me, who thinks I'm crazy, who doesn't understand me. So to me, those are really difficult conversations, and sometimes, probably like maybe 5% of the time, if you do everything right, you might have some success. And to me, what success means is you've presented this idea that how we feel affects our bodies in a real way and affects how we think in a real way. And therefore, when we perceive that we're not thinking straight, we can actually think about improving how we feel, and that will improve how we think. And that's a really tough message, because as soon as you start introducing the concept of emotions and feelings, oftentimes people check out. They're like, oh, no, I know exactly what's going on here, right?
Mm-hmm.
So
yeah.
One of the techniques that I use a lot is I use my own tendency to somaticize as the way to open up the conversation. So I will literally say to people, I get migraine headaches. And, you would think that as a psychologist, I would be one of those people who's really keyed in to how stressed I am. But I am not that person. I'm totally not that person. I go and go and go and go, and I have tons on my plate. And then I lose half of my visual field, and I have a big old migraine headache, and I come up with this like genius idea, oh, I must be stressed out, because stress is definitely a trigger for a headache. And so, I will take my medicine for my migraine and suffer through it, but then that week, I will make sure I'm doing things that I know reduce my stress. So I might go on an extra run or take another yoga class, or I have this wonderful meditation app on my iPhone that I use a lot. So, and you know, my point is that, hey, that a lot of us walk around feeling our stress in our bodies. Like literally, that word feeling is like literally feeling it. It feels like my shoulders are up here, or it feels like I'm tense. And so, to me, that physical symptom is a message from my body saying we need to reduce stress. And maybe that's happening with you too, right? And that's how I open up that conversation. And I have to say, you know, a lot of times it doesn't work. A lot of times people leave feeling not heard. But once in a while, I get, like, for example, 6 months after a feedback session with a young high school girl who was out of school for months with intractable migraine and chronic pain, they were all mad at me at that session. And then 6 months later, I got this beautiful Christmas card, and she had started running, and she joined the track team, and her migraines had reduced massively in frequency. She was back in school, and they said, you know what, we were really angry, but we got it. So that's an example of a difficult situation.
Yeah, yeah, absolutely. I've had similar experiences. It's very difficult when they're very invested in a medical explanation. But I like how you kind of normalized it. You made it something that, you know, everybody has to one degree or another. So it kind of opens up their mind to that possibility that that could be something possibly happening for them.
Exactly.
I had a question about when do you decide to give feedback to the caregiver or the family member versus when do you decide to speak to the patient, and how do you make the feedback different in those situations?
Yeah, that's a great question. You know, I have a lifespan practice, and so I see, you know, little guys starting at age 6, and I see geriatrics at 100. So my general rule of thumb is that with kids, I do an adult-only feedback session so we can speak frankly and plot and plan in terms of what to do with, you know, various caregivers, etc. And then I have a second feedback session that's usually shorter where I invite the child in with the parents. I think there's magic of the child hearing the message with the parents there. So that's what I do with the younger kids. With the Alzheimer's set, the geriatric set, I really do think there's magic in people hearing the conversation in the presence of their family, and the family members hearing it in the presence of the patient. In the research that we did, there is a big diversity of feeling around this. So some people genuinely feel that it's not a helpful thing to talk about Alzheimer's disease with someone who has it. I did a little research project that was published in the late 1990s, but it was basically, what's the so what of telling someone with Alzheimer's they have Alzheimer's disease? And the so what is basically, it doesn't make a difference. You know, people literally forget very shortly, and there's typically not a big emotional fallout. Caregivers tend to be much more worried about the impact than the actual impact. So, you know, because we can have conversations like, is it okay to drive? Do you need help in your home? How are we going to manage medicines? To me, it's really helpful to have folks there, even if they are frankly demented.
Thank you. That's very helpful to hear.
So we've got a question from one of our viewers here. They said, how do you give feedback to someone who failed performance validity testing? I think that's coming from the VA myself. That has often been, that's a question on my mind a lot.
That's
I was waiting for that question myself.
Yeah, it's tough. You know, the answer is it depends. You know, there are a lot of situations in which people are, for whatever reason, not putting forth effort on the tests. And in the vast majority of cases, they know they're not putting forth great effort. In most of those scenarios, there is going to be some kind of secondary gain, and it's very highly unlikely that they're going to admit to you that you are correct, right? So that's 90% of the situations. I do not expect the outcome, like to me, a good outcome of a feedback session when someone has failed performance validity tests, and I know the data is not good, it's not the moment where they say, oh, doc, you know what? I admit it. I faked the test, right? That just doesn't happen. That's not going to happen. So to me, my goal is not to have them agree with me. So there's no argument, there's no fight, there's no power struggle. I want to, as kindly as I can, explain that these were not the best test scores, and this is how I know. And there doesn't have to be the come to Jesus moment where they say, yes, I agree. So I will often use the X-ray metaphor. I'll say, hey, you know, these tests really rely on you putting forth full effort, right? I actually mix up my metaphors because I like the bicycle one as well. So I'll say to people, hey, you know, if you ride a bicycle, sometimes you pedal really hard, like if you're in the Tour de France, right? You're going to pedal like crazy. Sometimes maybe we're just out for exercise on a weekend. We're going to pedal hard, we want to sweat, but we're not pedaling as fast as we could. Sometimes we're coasting, sometimes we are not pedaling. And sometimes we're off the bike. We're not even on the bike, right? So, you know, I give every single person that comes in here what we call performance validity tests. And it helps me track, hey, how hard are you pedaling, right? And it's important to me to know that because that way I know, does this data really represent your best brain? And, you know, from how you performed on these performance validity tests, I know that this doesn't represent your best brain. And then I'll say, hey, does that make sense to you? Do you feel like at some points there were some things going on that maybe it was hard to pedal hard? And that can open up a conversation. So sometimes that might open up them saying, yeah. Dominic Carone has a beautiful way of explaining it, that he talks about engagement. Are you engaged? And he gets people to talk about, well, you know, were there times when you feel like you couldn't be engaged? So that's helpful. The other metaphor that I think is useful is to say to people, you know, you ever broke your arm and the X-ray technician says like, okay, hold it up, don't move, right? Because if you move, it's going to be a blurry image and we're not going to be able to figure out if there's a fracture or not. And so that's kind of like what happened on these tests. You know, you got to put forth your best effort or all the data is all fuzzy. It doesn't make any neurological sense. So it's not helpful in determining if you maybe have some subtle changes from that stroke or whatever it is, fill in the blank. So that's a way of kind of gently explaining what's going on. You know, there are also times when, you know, it's clear that the person will want to engage in some kind of explanation for why they weren't trying their best that we know from the research literature isn't true, right? So people might say, oh, yeah, I'm so depressed that, you know, I just can't think. And that's why I failed the effort tests. And frankly, some clinicians will say that too, but we know from good solid research that depression affects actually hard neuropsych assessment tests like the Western Memory Scale, but depression does not affect whether someone's going to pass or fail a crazy easy performance validity test like the TOMP. Same thing with chronic pain. Chronic pain is going to, you know, kind of dampen down the actual real hard scores on a battery. but chronic pain is not going to affect a performance validity test. So to me, it's important to open the conversation about why they may not have been engaging, but also not to accept and not to give them the idea that those alternative explanations that aren't really credible are what happened. So it's a little tough situation. Sometimes when there's no gain, like if I have a early dementia case, you might see where someone fails a performance validity test, and then later on, kind of as the testing goes on, they do a lot better. And I can have a conversation about, you know what, it seems like you kind of freaked out when you were confronted with a memory task. And, you know, it seems like you really weren't able to put forth good effort. It's almost like you kind of gave up, like, it's a memory test. Ooh, I don't even want to deal with this thing. Does that ever happen to you in daily life? Like, do you ever think, like, if your husband says, hey, I need you to remember this, do you ever kind of go, there's no way I can remember that, right? So it's a different way of introducing the concept of anxiety. Not that anxiety is going to make them demented, but that maybe in a moment where they feel that they are being asked to remember something and they have an inaccurate view of their memory, they might freak out and say, and that also can open up a therapeutic conversation.
Those are excellent answers, so thank you. I'm learning a lot in this as well. I had a question about billing and how you typically bill, or if you're able to bill for the feedback session, and if you can't, how you build that into the evaluation itself.
Yeah, so for me, probably about 80% of my practice is now just self-pay. So, you know, people come to see me for learning disability evaluations, people see me for whatever the evaluation is. They typically just pay out of pocket, and then they deal with their insurance company and they get reimbursed for whatever. So in those scenarios, I just say, hey, I value my time for feedback sessions, and so here's my hourly rate, right? So that's how I deal with that. Because I love seeing Alzheimer's and related dementias, I do take Medicare. And so there is about 20% of my practice where I see Medicare patients. And I will say that there are some changes coming down the pike, most likely. But for now, you know, how most people handle it is that they bill a feedback session through the 96118. Which is the neuropsychological assessment, the psychologist doing the work. Sometimes people bill with psychotherapy codes, but that's actually not necessarily as accurate. And in the world of Medicare, you really want to try to be as accurate as possible. There are different rulings on this from different compliance officers. So if it's working and no one's squawking about it, and it's using a psychotherapy code as opposed to a neuropsychology code, it's okay to leave it. And again, you know, once in a while, the American Psych Association Practice Organization will come out with some recommendations about best billing practices. And actually, a little advertisement for them. Anybody who's not a member of APA practice organization should definitely be, because they totally have our backs around these billing issues. So you can hop on the APA website and get some more kind of fleshed out advice about the billing with the CPT codes.
Great, thank you.
So one of the questions I had also was, you know, I've heard feedback discussed as an ethical obligation. It's our obligation to provide feedback, and I wanted to know kind of your thoughts. How are ethics involved when we give feedback?
Yeah, that's a good question. So it is part of our ethic code that we need to give feedback about our assessment. You know, it's so interesting to me. Back in the day, so when our field began, the ethic was really to give feedback to the referral source. So a primary care or a neurologist would send a patient to us. We would do the assessment, come up with our findings, and then write a report, send it to the referral source. And oftentimes there was no feedback to patients. And I think it's also one of the reasons why our reports have been so long and so wordy, because we have to kind of, over time, kind of convince these unnamed referral sources of our logic, right? So, now we actually did a little survey looking at how common it is for people to do feedback sessions, and it's something like 90-95% of people give feedback sessions at this point. And we actually have asked physicians, hey, do you want to do the feedback, or do you want the neuropsychologist? And overwhelmingly they want the neuropsychologist to give the feedback. So there's an ethical obligation there, kind of a norm in our field over time of giving feedback. And even when people are on let's say a tertiary care team, like say you're on a transplant team, or you're on a memory disorders team, where maybe the neurologist or the neurosurgeon wants to give the ultimate diagnosis, a lot of folks will still give a good hour of feedback because there's so much to say, right? There's so much explanation. Even if you're not the one to say it's Alzheimer's, there's a huge amount of explanation about what we're looking at and what it means, and what is the so what in terms of daily life, and what interventions can we do, and how do we get Aunt Sally on board who's never believed in this diagnosis. So there's an enormous amount that we can do that is really helpful and therapeutic. It's, to me, the ethical piece is it's the so what of having done this thing. You have this knowledge about this person's brain function, and unless somehow you are communicating it in a way that they have access to, that knowledge doesn't do anything. It's just in this box. And so to me, the ethical piece is how to get out of the box into people's lives so that it's useful and helpful and genuinely therapeutic. It's clinical. That's the clinical moment. Mm-hmm. I should say, the other piece of the ethics is that there's a little bit of a different ethic around giving feedback when you're in a forensic situation. And so typically there are many forensic situations in which you don't give feedback, but you want to consent people up front and let them know that that's the case.
Thank you. It's very, very insightful. A lot of those points I hadn't thought about. I appreciate you sharing.
Sure.
I had another question about how you would, based on, I know we talked about a specific situation with effort, but in terms of how people react to the news, and sometimes it can be good news, sometimes it can be, you have ADHD, but you're going to get accommodations for that, and sometimes it can be, well, you have this neurodegenerative disease, and unfortunately there's not a lot of treatment. So how do you adjust to people's reactions, and how do you accommodate those reactions?
It's such a critical question. I'll share an experience. This winter, I attended a boot camp at the Alan Alda Center for Communicating Science. I didn't even know this existed. So Alan Alda had this PBS show explaining science. It was like a Nova show, and he did it for years. And he got really interested in this idea of some scientists communicate so beautifully, and we can understand what they're saying, and other scientists don't know what they're saying. It's all of their wonderful work, which is so great. It's not accessible by the general public. And what he felt is if it's not accessible, no one's actually using it, and no one's going to fund it. And so science is in trouble if we don't teach scientists how to communicate. So they give these, day-long and weekend workshops, but once a year they give a week-long boot camp. And half of the day is kind of stuff that, came up in my research, like metaphors and stories and that kind of thing. The other half of the day was improv training. And I was terrified. I was like, oh my God. But literally we spent hours every day doing improv. And the genius thing, it turned out to be totally fun. I loved it. The genius thing about improv is that you genuinely have to be there in the moment, unscripted, literally responding to the needs of the person next to you. And the whole ethic for improv is you can't say no. You got to say yes and, right? You got to take the toy that they're giving you. It's like a perfect Winnicott moment. You got to take the play object and accept it and then transform it and hand it back, right? And so many times in our feedback, we are talking, we give this maybe impenetrable, jargon-filled whatever, and people say, you mean this? And we're like, no, right? It's this. And we keep pushing our toy at them, and it may not work for them, right? So one of the things that we really have to do is when someone gives us something, it could be body language, it could be a small word, it could be an emotional response. We need to stop what we're doing, right? Put our toy down, really accept what they are giving us in the moment, and be willing to really be there with them, and then do something different than we had planned. So if someone, their face crumples and they're upset that they got a good score, we take that and we really listen to what they're saying, ask questions about it, find out about that thing, and then we respond. Or if they are, exquisitely sad about a moment, we are there with them. And that is the therapeutic moment. That's what we learn when we do psychotherapy, if we learn to do psychotherapy well. I actually have one of my mentors, Linda Vincent, who's just wonderful. He actually has a practice of meditation before she goes into a feedback session.
Wow.
Yeah, I when I heard that, I was like, oh my gosh, that's so spectacular. She sits for a moment and meditates on what it must be like to be her patient, not knowing anything about neuropsychology, being worried, maybe worried for their child or whatever, and what is it going to be like to hear what I'm about to say? And that helps her kind of get into that moment. So whether it's meditation or improv or psychotherapy training, I think that's really something that we need to kind of spend a lifetime really working on and developing in ourselves.
Thank you. That's very helpful information. I'm getting a lot from that as well.
Yeah, absolutely. So this will probably be our last question, and then we'll wrap up with you. I wanted to kind of broaden it to just talk about what the experience was like writing a book. As early career professionals, if that was a goal for us, would you have any tips about like when in our career it would be most beneficial, or that we should avoid trying to write a book during certain times? What are your thoughts about that?
That is so funny. Well, I will liken childbirth because right after childbirth, you're like, what was I thinking? I'm never doing that again. So I'm actually 3/4 of the way through another book, Testimony That Sticks, where I'm interviewing forensic psychologists and neuropsychologists, also judges and attorneys this time, gathering similar information. And I have to say, it's huge fun writing a book. I really enjoy getting to write whatever I want. As neuropsychologists, we have such a formal, specific way of writing, and we have a lot of constraints. We don't have a lot of degrees of freedom. And so for me, the whole process of writing a book it was wonderfully creative, super fun. I really enjoyed it. It was also like a crazy load of work, like insanity level of time that you put in with the research, but also when you give it to the editor, that's only the beginning. There's like, then you got to, you know, copy edit, and it's a lot. So basically there is no good time to write a book because you are too busy, right? There's no good time to write a book. If you pick a topic that you love and it brings you joy, then it's your hobby, right? You could be, you know, painting or doing ceramics, but you know, you're writing a book. So it's just, that's how you fit it into your life. I wrote chapters at various times with little babies on my lap, you know. I mean, you kind of do it. You fit it in. If you are interested in writing a book, the number one thing I would recommend is going to the Harvard University every year has a several-day workshop on how to write a book if you are a PhD or MD. So it's for psychologists and physicians. And these days it's not called book writing, but it's just generally communicating to the general public, but it's really about book writing. And I did that before writing Feedback That Sticks, and it was spectacular because it teaches you, you know, you don't write the whole book, you write a proposal. And then the proposal is accepted and tweaked, and the final book is very different. So no publisher wants a manuscript. What they want is a proposal that they have the opportunity to take part in shaping. And the seminar really helps you learn to write a proposal. So I have had several colleagues who have gone through that same seminar and have just loved it. So that's my number one piece of advice. Probably they do that other places in the country, but the one I have experience is with at Harvard, and it's just beyond. It's really great.
Excellent. Definitely a labor of love, it sounds like. Yeah, you have to love what you're doing or else it's painful. Well, thank you so much, Dr. Postal. We've really enjoyed having you and sharing your experiences with us. I've learned a lot personally, and I'm sure the rest of our viewers have as well. So we appreciate the time and the effort that you've donated to us.
Well, thank you. It was my pleasure. I have to say I've never heard of a virtual happy hour, so I was not asked to do this. This was great.
It's the wave of the future. There will be many more.
We'll have to invite you back for forensic as well. We'll have to do a virtual happy hour.
That's very interesting. All right.
Okay. Good night.
Bye.